Hi everyone, welcome to 150th Stanford MedAI Group Exchange session. This week we have David Barrett from Google DeepMind to talk about their work on collaboration between clinicians and VLMs for radiology report generation. David is a staff research scientist at Google DeepMind in Dublin, working on biomedical applications of AI. His research background is in theoretical physics with an undergraduate degree from Trinity College Dublin and a PhD in machine learning and computational neuroscience from the Gatsby unit at University College London. His work focuses on biomedical applications of AI in domains like radiology, dermatology, clinical documentation reasoning, clinician AI collaboration, AI diagnostic dialogue, cell signaling, and gene regulatory networks. So, David, thank you very much for joining us today. But before we start, how would you like to take questions? Can we interrupt you in the middle, or do you want all of the questions at the end? Or do you have specific breaks in your talk?
Yeah, I'm happy to take questions during the talk. If they're longer ones, maybe at the end. Yeah, thank you.
Perfect. So in that case, let's make this session as interactive as possible, and let me hand it over to our presenter.
Thank you, Mara, and thanks for the invitation and introduction. I'm a big fan of the Stanford MedAI talk series. It's an honor to be presenting the 150th episode, I guess, today. So, as you said, my name is David Barrett, and I'm a research scientist at Google DeepMind, based in Dublin, in Ireland. And my research is focused on healthcare applications of AI across a variety of domains: cell signaling, gene regulatory networks, through to other areas: diagnostic dialogue, dermatology, clinical document reasoning. But today I'm going to present some recently published work focusing on collaboration between clinicians and vision language models in radiology report generation. This work is the result of a large collaboration with many brilliant colleagues, especially my close collaborators in this study, Ryotaro Tano, Alan Karthikeya-Silingam, and Dira Katena. So, just by way of introduction, we know that radiology plays an integral and increasingly important role in modern medicine. It informs diagnosis and treatment and management of patients through medical imaging. Of course, there's a global shortage of radiologists. That restricts access to expert care and causes heavy workloads for radiologists, resulting in delays and errors in clinical decisions. But then on the other hand, already approximately 1 in every 3 radiologists in the United States are using AI as part of their clinical workflow. And there are more than 200 FDA-approved products now, just for the past decade, of this category. However, the vast majority of those approved AI applications, they focus only on classification and quantification of some very specific pathologies, whereas we know that most clinical workflows have a much richer multimodal interaction between clinicians, medical data, and often mediated through open-ended natural language, and radiology report writing is one example of that type of open-ended communication and interaction. So, in a typical clinical workflow, a radiologist or a clinician would request an X-ray image, and that image would then be sent to the radiologist. The radiologist examines the image, usually without meeting the patient, and then writes a report describing the findings and general impression. And then that result, basically that allows the result to be communicated with nuance, synthesized in a broader context, and goes much further beyond simple disease classification. I think classification of X-rays was really a workhorse of health AI research for many years, especially given that radiology is one of the most digitized branches of medicine. But now with all of the recent developments in large language models, it's really opened up the field to exploring these richer settings with language. So our goal in this work is to develop an automatic report generation system, something that's capable of producing a complete free text description of the medical image. Basically, we want to build a system that can take an X-ray image as input and produce a text report as output, similar to the task of a specialist radiologist. So in addition to that, we wanted to develop and explore assistive settings where clinicians and AI can collaborate together to write radiology reports. I think this is especially important given that most AI tools that have been improved for clinical decision making have been developed for an assistive rather than an autonomous role in care delivery. So, yeah, I think it's really important and timely in that context to research and explore the properties of such collaborative modes. So our approach in this work is to train a general purpose language model as a radiology specialist. So the first step is to use the Flamingo Foundation model as our general purpose visual language model. So Flamingo, it's a general purpose family of transformer-based visual language models. It takes visual data as input, interleaved with text. It produces free-form text as output. The key architectural components are the language model that operates on the input text and generates the output text, the vision encoder that maps visual data into the same representation space as the text input, and also the connective module that integrates both modalities. So the combination of these different components and cross-attention layers as the connective component offers a very expressive way for the language model to incorporate visual information for next token prediction. Now, there are several versions of Flamingo with different scales. The version that we're working with is a relatively parsimonious 400 million parameter version. Now, one of the issues at the outset for this work is that in training Flamingo, there were no X-ray images as part of the original training set. So we need to address that if we want our model to be able to interpret and reason about X-ray images. So to that end, we've trained and evaluated our model using two large de-identified data sets of chest X-ray images and radiology reports from the United States and India. So the data sets are the IND1 data set. That consists of X-rays and reports from 5 regional centers across a large hospital group in India. It's a fully de-identified data set, consists of inpatient and outpatient settings. There's slightly more than 250,000 frontal chest X-rays alongside reports. And then in our experiments, we're using the same split that's used in previous studies, so just slightly more than 250,000 training examples, almost 5,000 validation examples, and close to 8,000 test examples. And then in the MIMIC CXR dataset, this one's well known, many of you are probably familiar with it. It's the largest public chest X-ray dataset, and it contains X-rays and reports from the Beth Israel Deaconess Medical Center Emergency Department in the United States. So in our experiments for MIMIC CXR, we're using the official split provided by the dataset. So in that, we've got just shy of 223,000 training examples, more than 1,800 validation examples, and 3,300 or so test examples. Now, we use two different data sets because, well, we know that the contents of radiology reports, they tend to differ between geographic regions and clinical contexts. So, for instance, the IND1 data set contains a greater proportion of normal images, those that don't contain any abnormal clinical findings. Whereas on the other hand, the MIMIC CXR dataset contains a larger proportion of abnormal images. Also, the MIMIC dataset reports, they use a more so a semi-structured free-form writing style, whereas the IND1 reports use I guess a slightly more structured style in typically when they're being written. So finally then, in the next step, we evaluate Flamingo by performing comparisons to human radiologists. So to do this, we give an X-ray image to Flamingo and compare it to a radiology report written by a human radiologist for the same X-ray image. This is a difficult task since the text output consists of some open-ended text and contains highly specialized medical terminology. So, like for instance, if you look at this one, the radiologist has written that there's a basilar opacity seen on the lateral view and best corresponds to a retrocardiac opacity, which is difficult for non-specialists to understand. It's difficult to say, does this correspond to what the AI has written? Is it different? Even for non-specialists, it's difficult to make that judgment call. Whereas, of course, in comparison to classification, any non-specialist is able to immediately look at the results of a classifier and identify whether or not it's in alignment with the ground truth. So to compare the two reports, we use a standard clinical score, which is called Chexpert. This score, it measures the similarity between generated text reports and original reports. The score ranges, it's a number, so it ranges between 0 and 1. 1 denotes the highest degree of alignment between the medical assistant generated report and the human report. So as you can see here, there's been steady progress on this report writing task going back to 2020, I guess at the time when LLM started to become increasingly capable. And what we've found in this work is that Flamingo CXR, our model, achieves state-of-the-art performance with a 33% improvement relative to the closest competing model, and once the model is capable of generating findings and impressions. So in addition to Chexpert, we also measure a set of widely adopted natural language generation metrics, along with the RadGraph F1 score. So the natural language metrics, for those ones, like we look at CIDR, the BLUS score, Rouge score, the results are mixed. We achieve competitive BLUS and Rouge scores and attain a somewhat compromised CIDR score. But that is consistent with, I guess, the general observation that very often these natural language metrics don't really reflect the clinical accuracy of generated reports, possibly because the language is so technical. Perhaps these general purpose natural language metrics are ill-suited to measuring the similarity or discrepancy between these reports. Also, many of the best performing model scores are provided only for generation of report findings alone. So a lot of, when radiologist writes a report, they have a findings section and an impression section. And for many of these previously reported benchmarks, it's only on the findings section that a score is given. And among some methods that do give findings and impressions, Flamingo also outperforms the previous state-of-the-art as measured by the RadGraph F1 score. And still does reasonably well relative to the ones that only focus on the findings, which of course is an easier task because there's less text. You're only trying to generate a portion of the full report. So yeah, we're quite happy with that result. But nonetheless, despite some good results with these measures, it's difficult to interpret the numbers. How good is let's say 0.519 Chexpert score? What does it mean? This gets to one of the issues in this field. Even though there has been a lot of publications on AI-based report generation, as we can see here, and there's a clear potential to improve the radiology workflow. There's a compelling application case here. One of the issues is that it's very difficult to meaningfully evaluate the clinical quality of the generated reports. Really what we want to know is, how do expert clinicians rate the output of our model? Would they actually recommend the reports generated by our model for downstream clinical care? Or are they worse than human experts who might write the same report or write a report for the same X-ray image? And it's difficult to take a score of 0.519 and say, yes, it's good enough now. And that's one of the issues that has been the field has been confronting for a number of years. So we took the approach to answer this question directly, to turn to a group of board certified radiologists and ask them to compare two radiology reports for the same X-ray image, the AI generated report and the report written by another radiologist. So the experts, we asked them which one is better for downstream patient care. Now, the radiologists, importantly, they're different from the ones who wrote the original reports. Also, they don't know the source of the report. When they're comparing models, they don't know which one is written by our model and which one is written by a radiologist in the original clinical setting. For the study, we recruit a group of 11 radiologists from the United States, 16 who are based in India, all with board certification. And for each evaluation, we ask 4 radiologists to evaluate each report, 2 from the US cohort and 2 from the India cohort. And that allows
David,
us
can I
to...
ask you something quickly?
Yeah, absolutely.
Yeah, I'm very curious about this workflow actually, like how you do the actual person validation. But one thing I find out is like always kind of critical that this chest X-ray has been done for different like clinical history, right? Like for different purpose. Some chest X-ray has been done for trauma, some chest X-ray has been done for, I don't know, for just evaluation of the shortness of breath. So their reporting also depends on what was the cause for ordering the exam. So I don't know, have
Yes.
you given any thought about also the radiology selection or the evaluation that based on the clinical history or based on the reason for ordering, should we separate the reports? Because I think every report has been formulated slightly differently.
Yeah, this is an interesting point. So in training and in the evaluations, we don't give extra clinical context. We do literally only give the image and the reports. So the raters have to judge the quality without any of the extra clinical context. And it's the best we can really do with the data sets, with the data that is available. But I think it's a very good point. Like, going forward, it would be really interesting to explore the to run a study like this in the full clinical context.
Right, because you understand, right? The radiologist never writes a report without knowing the patient history. Then why we are expecting an AI to write a report without knowing the patient history?
So it depends. Like very often radiologists are given very minimal information
At least
about
some information, right? Like they at least know the reason for the order. So if it is
So
because of shortness of breath or if it is because of the patient, I don't know, like the trauma or the patient is in ICU, at least they have that information. That
usually they know where the request is coming from, like if it's
yes,
ICU,
yeah.
and for instance, the like the Mimic CXR data set, for instance, they're all coming from an emergency
But they
department.
have a very detailed idea about the patient clinical history while writing a radiology report in the ICU.
So it depends on this. So we don't know for certain. Like for the radiologists that I've spoken to, they anecdotally have told me that it depends. Like sometimes they're given details, sometimes they're not.
But don't you think that their
Um,
report quality also based on that how much information they have been given?
Absolutely, and this, when you speak to radiologists, they will say that in the absence of the full context, it can be difficult for them to write a report, and they'll have to guess sometimes about what the
Right.
question might be, maybe perhaps based on what department in the hospital the question is coming from. But then very often, when they look at an X-ray, they will report on the abnormalities that they see. Even if something, if a request is made for one, say, set of symptoms, and they see something alarming,
Right. Right. Right.
it would be, it would be good practice very often to mention that in the report. So
Right.
there is a certain level of objective quality.
Right.
But I think it's a very good point, and it will be amazing to have like richer data sets as always.
Okay, so in your evaluation, you are not really separating that. You're in your evaluation, like you are just treating every reports in the same way.
Exactly.
Okay,
Yeah.
okay,
Yeah.
makes sense.
Yeah. So, like
I think
we do.
David, I think we do have some questions in the chat about the data sets. So somebody's asking which hospital in India. I'm assuming that's confidential, or can you share that? And the other part is the India data set publicly available or no?
Yeah. So it's from a hospital group in India with hospitals from Bangalore, Chennai, Hyderabad, New Delhi. The data set is not publicly available,
Mm-hmm.
but the providers of the data set can be contacted.
Okay.
And if somebody wants access, you can certainly reach out to them. For us, we were eager to work with a data set from a different setting, so that our results were robust to the types of variations that one might expect to see across different clinical contexts.
Makes sense.
And especially the India hospital group consists of inpatient and outpatient X-ray images and reports. Whereas Mimic CXR, because it's emergency department, they'll often be much more serious in their nature. The Ind1 dataset contains many more normal X-rays. And also the reporting style is a bit different. They're more structured in the Ind1 data sets. And some of those differences might reflect, say, the stylistic preferences that are taught by, say, the radiology trainers in a particular medical system. It might also reflect different regional and hospital guidelines. Within a region, there might be different guidelines across different hospitals, different guidelines. So yeah, it's important and I think interesting to make sure that our work and models are robust to these things. So the labeling interface then that we use, this is the interface we use. So the raters are provided with a frontal view at full resolution, a radiology report generated by our AI system, and the original report written by the radiologist, as I just said.
Sorry, David, I probably missed that part. So you just used the frontal image for training, right? You did not use the lateral image for model training.
Exactly. Yeah.
Okay.
Yeah. So some of those images are in the data set, but we leave them out, which is standard practice in some of these, in many of these benchmarks. We use the very same splits that are used. Yeah. So for each case then, the raters, as I said, they're unaware of which report is the ground truth, which one is generated by the model, and they're asked to describe their preference out of the three options, either report A, report B, or equivalence between the two. And the interface, it also allows the raters to zoom in and out of the image as needed. And that's something that clinicians are able to do in practice. Yeah. So here's an example of an X-ray image and corresponding report in which the AI report was unanimously preferred by our panel of radiologists. So that for each image, we ask 4 radiologists, 2 from 2 of the US cohort and 2 of the India cohort to rate the quality of the reports. So the radiologists found that the AI report in this case was more consistent with the radiograph and was more accurate. They disagreed with the original report, in this case writing that left lower lobe pneumonia is over-enthusiastic in the limited setting, and that if there is clinical suspicion, that a repeat radiograph is warranted. And that's more consistent with the AI report, which calls for a repeat radiograph if clinical suspicion persists. So I think that illustrates the capability of the model in a setting where, in this example, it outperforms a human radiologist. But then, of course, there are also many instances where the human reports are preferred compared to the AI-generated report.
But David, for example, this report, right, that you were showing, that the previous one that you were showing before, that here actually the impression section is missing in the AI report. So
so it's interesting. The impression in this one was that left lower lobe opacity likely reflects pneumonia or aspiration. But I think in this case, I think there was some question about the impression. For some reason, it decided not to generate that piece. But in this one, for instance, it does give the impression, even though in this case now, the clinician's report was unanimously preferred. So in this case, the raters agreed that I think mild pulmonary vascular congestion is present, which is not identified in the AI report. And there's also instances then where there's a split panel. So here, half of the panels prefer the human report, and the other half prefer the AI report. So the radiologist raters found that the human report was more detailed and more accurate. The raters agreed that mild pulmonary vascular congestion is present, which is not identified in the AI report. So these are anecdotal examples, but if we want to go beyond a handful of anecdotes, we need to expand our study. So we do that, and we look at several hundred radiology reports just over 300 mimic reports and 300 IND1 dataset reports, and collect preference ratings from 4 expert radiologists in our panel for each image. So we find across both data sets, the generated reports from Flamingo are often considered preferable or equivalent to the ground truth report. Then looking more closely, what we've done here is to group our results according to the level of agreement between reviewers, with reports that receive a unanimous vote in favor of the AI reports colored in dark blue, through to those reports receiving a unanimous vote in favor of the human reports colored in light blue. For instance, you can see that 36.7% of IND1 reports are rated as equivalent or preferred by all 4 raters. That rises by an additional 21% if we include cases where there's a 3 out of 4 vote, and another 20% if half or more of the panel votes for it. So as such, for the IND1 data set, a total of 77.7% of IND1 cases, Flamingo CX reports were rated as equivalent or preferred relative to the original clinician report by at least half of the radiologists in our panel. Whereas for Mimic, we see that 56.1% of cases were rated as equivalent or preferred relative to the original clinician report by at least half of the radiologists in our panel. So,
David, I think we have a few questions in the chat. The first one is about the results. Many reports in Mimic refer to the past studies for the same patient, and it can introduce potential noise to the model training and also evaluation. So did you take any steps to control that temporal information? Or
yeah, we didn't include those kind of reports, the ones that had multiple time series reports, either in training. Yeah.
Okay. Exactly. And there's another question about the data de-identification as well. If you want to keep that discussion to the end, we can move forward. Or if you want to discuss it now.
Maybe we'll do it at the end. It's fully de-identified data set, but maybe I'll go to the end and then field questions. Yes. So I don't run out. Yeah. But if there's a pressing question, I'm happy to answer. Sure. Yeah. So overall, they're, I think, reasonably strong results. It's clear the Mimic reports are more challenging to model, though. I think it's not entirely surprising, though, because, as I said before, the Mimic, well, first of all, the Mimic data set is a bit smaller, but also there's a greater diversity of reports. There's a larger proportion of abnormal images compared to the IND1 setting, where there's quite a few normal images. It's also then interesting, I think, to note that there's a substantial degree of disagreement within our panel. So in most cases, our radiologists, they're not actually in agreement, either in favor of Flamingo or the radiologist reports. So only in 44% of IND1 cases and only in 27.4% of Mimic cases are they in agreement with each other. And I think that reflects the difficulty of the rating task, and also the variability amongst raters and preferences for reporting styles. Also, I think by reporting, on the positive side, by reporting this progressive degree of agreement and disagreement, the results can be interpreted then by different audiences depending on what level of agreement you are interested in. Like, there might be scenarios where a preference vote from a single radiographer from our panel of 4 would be sufficient for the application. And so maybe some other application where really you need full unanimity. So this could be something that a reader could be free to decide on depending on their application case. And we can delve further into the results with some subgroup analysis. Here, we separate out the ratings according to whether or not the X-rays contained clinical abnormalities or not. Interestingly, we see that for normal IND reports, 75% of Flamingo CXR reports were rated as equivalent or preferred relative to the original clinician by all the radiologists. That rises to 94% of cases for half or more of the radiologists in the panel. Then that drops to about 70%, 69.5% for abnormal IND1 cases, and a further 55.5% for abnormal Mimic CXR cases. I think, again, reflecting that increased difficulty of the Mimic data set. Now, one issue with all of these results, with all of these pairwise preferences, is that they can be difficult to interpret, especially for cases where maybe both radiologists and AI reports contain errors. So from that context, we run a second task to go beyond pairwise comparison. So in this task, we asked radiologists to identify errors in the radiology reports. The expert raters, again, are provided with an X-ray image and a radiology report for the image, consisting of findings and impression sections. And their task then is to assess the accuracy of the report by identifying errors in the report and providing suggested replacements. The interface, again, it's somewhat similar to what I showed before. The raters are asked if there's any part of the report that they don't agree with. If so, they're asked to select the passages they disagree with, specify whether the error is clinically significant or not. We say that a clinically significant error is one that is potentially harmful, that might influence the downstream clinical decision for the patient. We also ask them to provide a replacement sentence for the selected passage and to also select the reason for the disagreement. And we're giving them a few options here, whether if there's a finding that don't agree with, whether there's an incorrect location specified in the report or an incorrect severity of finding. And we ask the readers to evaluate the ground truth reports written by the experts and the generated ones to detect errors in both human and AI written reports. So yeah, here's an example of an AI report that contains an error. We see in this predicted report, the Flamingo identifies a dual lead pacemaker. However, the expert rater identified this as an error, suggests a replacement sentence that a single chamber pacemaker is present. And in contrast, the original radiologist does not make this error either, writing that a single lead pacemaker is present. But it also goes the other way. Human radiologists also make mistakes. In this case, the radiologist said that a condition called cardiomegaly is present. However, our expert rater identified that as an error, suggested a replacement sentence that the increased cardiac silhouette is likely due to position and technical region, that this error also highlights, I think it highlights the difficulty of the task for radiologists and AI alike. Features in an X-ray image can be misleading depending on the position of the patient, which was the case in this example. So in contrast here, the AI report, it doesn't make that error. It writes that the cardiac silhouette is top normal. So yeah, we should, and we do again, go beyond anecdotal examples. We expand on our error analysis, again, to several hundred radiology reports and look at the statistics of the errors, both in the AI and the radiologist reports. So as a headline result, I guess we find that a non-negligible percentage of the radiologist reports contain clinically significant disagreements for both mimic and in-one data sets, more than 10%. The relative frequency of errors between the AI system and the human experts varies across the two data sets. For in-one, the model makes fewer errors on average than the human experts, but then the frequency of clinically significant errors is marginally higher. And then on contrast, for the mimic CXR data set, more clinically significant disagreements on average reported in the AI-generated reports than in the original reports. So next then, we delve into the types of errors that were detected. You might remember that was one of the questions, what type of error is detected. There's several options: an incorrect finding, an incorrect location, or incorrect severity. So we find that both for the model-generated reports and the original ones, the most dominant category of error across the two data sets is the incorrect finding category. And then across most categories, incorrect locations occur more frequently for AI reports than radiologist reports, which I think is kind of interesting. Perhaps it reflects some deficit in the ability of our model to certainly match the spatial reasoning capabilities of radiologists in this case. So I would say a picture is starting to emerge where radiologists and AI, they both make some errors, but the types of errors can be different, which then leads us to investigate those differences, to the differences and the intersection of cases with errors between original reports and the ones generated by our model. So we find that many of the errors made by humans are different to the errors made by AI and vice versa. For instance, of the clinically significant errors in the mimic data set, only 56 reports contained clinically significant errors in both AI and radiologist reports, whereas 56 reports only contained errors in the human reports, but not the AI reports, and 93 reports only contained errors in the AI reports, but not the human reports. Similarly, for the end-one data set, the overlap of reports with clinically significant errors is smaller than the non-intersecting non-intersecting set with 62 in the intersection of clinically significant errors and 92 outside of the intersection, occurring in AI reports only or human reports only, but not in both. So yeah, it's interesting. So the presence of those two differences, I guess, in errors between the human written reports and AI generated reports, I guess suggests that there might be some complementarity here between AI systems and human radiologists. Perhaps we can somehow combine the radiologists in our model, maybe get the best of both worlds, leverage the advantages of AI while mitigating some of the errors and disadvantages. But then, of course, there's also the possibility that we might get the worst of both worlds, errors from AI, errors from the human radiologists, all combining into something that's not good. So yeah, this prompts our next question. Can clinicians and AI collaborate together to improve report quality? So to explore this question, we consider a collaborative setting in which Flamingo produces a first draft report for a given X-ray image. Then a radiologist reviews the X-ray and reports and edits the report if necessary. They replace any sentences from the first draft with an alternative sentence if needed, or they can add entirely new sentences to the report if needed. And they can make as many changes as they want. So yeah, to evaluate those, we again ask our expert raters to indicate their preference for, in this case, either the collaborative report or the original clinician report. And we use the same pairwise preference interface described before. Again, we make sure that the clinicians who were involved in the editing and collaboration weren't involved in the preference testing. And also, once again, the raters don't know which report is the ground truth and which one was generated by the AI model in collaboration with clinicians. So here's I guess, a worked example. Here we see a first draft report generated by Flamingo. And then we see a radiologist, in this case, has decided to replace sentences in the AI report that mention pneumothorax with new sentences that mention hydropneumothorax instead, highlighted in red. Next, then, we ask the panel of adjudicating radiologists to rate the quality of collaborative report relative to the report that was written by the radiologist originally without the assistance of AI. The original report here on the left. So in this case, all 4 radiologists in the panel indicated that the collaborative clinician AI report was preferable or equivalent to the original mimic clinician report. And they gave some reasons. They said that the collaborative report was more succinct, it conveyed the clinical findings better. And for reasons like they made a statement about the right side pleural effusion and hydropneumothorax being relevant. Whereas in contrast, for the AI report without the edits, all 4 radiologists indicated a preference for the original clinical report. And reasons given were that there was no residual pneumothorax, and also that the lung findings were more accurate. So yeah, as usual, we go beyond anecdotal examples and once again collect preference ratings from 4 expert radiologists in our panel for all the collaborative reports. So we find that for 53.6% of mimic cases, collaborative clinician AI reports were rated as equivalent or preferred relative to the original clinician report by at least half of the radiologists in our panel. In comparison, for reports generated by Flamingo alone, without collaboration, only 44.4% of reports were rated as equivalent or preferred relative to the original, again by half or more of the panel. And we observed similar findings for IND1, where the collaborative reports were rated as preferable by half more of the panel in 71.2% of cases, in comparison to 51.2% for those generated by Flamingo alone. So I guess, we've observed the AI reports with human edits, they don't actually reach perfect preference or equivalence compared with the original reports. You might have expected, okay, the radiologists will collaborate, any errors will be corrected, and now we should reach a point where the panel are unanimously satisfied that this collaborative report is as good as it can be. It's at least equivalent, if not better, than the radiologist reports in the beginning. But we don't see that. Things don't get worse, but and there is a positive effect. But the explanations for why there isn't a huge effect is that, first of all, there is this baseline level of inter-rater variability. Our panel do disagree substantially, as we saw at the outset of the first task, about their judgment of the relative the relative value and quality of different reports. And also there are other effects. So a clinician working in collaboration with AI might actually produce a report that's less accurate than a clinician working alone. There might be some anchoring effect potentially, which might lead to a clinician actually performing worse. But nonetheless, we do see very encouraging results. The results aren't worse, and I think given those limitations, I think it is really encouraging to see that instead of having a compounding of errors, which we feared at the outset, we instead see a synergistic effect. And I think this is particularly promising given that most AI tools that are approved for clinical decision making are deployed in an assistive rather than an autonomous setting. But clearly, I think more work needs to be done to delve into the the modalities that might improve the collaboration, like whether some sort of training protocol or other information would be helpful, and to also investigate in more detail the various situations where collaboration is synergistic and where you might have compounding of errors, and to see if those various situations can be addressed. But I certainly hope that this work encourages people to explore this collaborative direction much more so. I think that is where the field is likely to go, especially given the safety and other reasons, and also that almost all of these AI tools that have been already approved for clinical decision making are actually deployed for assistive rather than autonomous settings. So it's really important that we keep pushing this envelope of research. Then just going back to the earlier results, in the fully autonomous setting, I think we also saw some room for improvement with the MIMIC dataset, where the original reports are, they're more detailed, they're less templated than the end-to-one dataset. Perhaps more training data would be useful, and then also, going beyond these datasets, there was a question about X-ray images where there's multiple time points involved, or where there are different views. We haven't considered those settings, but I think it would be really valuable and interesting to push in that direction. But I would guess, further training data would be required to fine-tune the model to be comparably performant in those settings. So, just to summarize this first part of the talk, we've built a state-of-the-art report generation system, state-of-the-art at the time, and performed one of the largest expert evaluations of AI-generated reports by engaging this board certified radiologists. We observed that it was like 56.1% of Flamingo CXR intensive care reports are evaluated to be preferable or equivalent to clinician reports by half or more of our panel. That rises to about 77% for inpatient, outpatient settings, and to 94% for the subset of normal cases. I think already that strong performance indicates and suggests potential clinical applicability, especially for the normal inpatient, outpatient settings. And then for the reports that contain errors, as we've seen, we've developed this assistive setting, which I think is an interesting demonstration of clinician AI collaboration for radiology report generation, hopefully indicating new possibilities for potential clinical utility. If you're interested in reading more about the details of the work is published now with all the details at the start of the year. As I said earlier, though, it's a culmination of a large team effort, and in particular with my colleague Rita Artano and Karthik Sillingham, Ira Katina, and many other brilliant colleagues. Perhaps in the final few minutes, I could talk about some of the most recent developments, because a year is a long time in health AI research, as we all know. So perhaps I'll briefly take a few minutes and then save some time for questions at the end. So, as I said, a lot has changed in the last year, certainly in the last number of years. At Google, the transformer model was a very important innovation, and since then there's been a whole series of transformer-based innovations, from Barret, Flamingo, through to Pan. And of course, everyone, many of us are now focusing and thinking about the Gemini era of models, which are our largest and most capable language models. Gemini was built from the start to be multimodal, to reason about all sorts of multimodal inputs. And when Gemini was first introduced, our group got together and developed MedGemini, which is a family of highly capable multimodal models specialized in medicine. And these models inherit a lot of multimodal and non-context capabilities of the foundation models of Gemini models. And we enhanced them then in this work with clinical reasoning capabilities through self-training, web search integration, fine-tuning, chain of reason prompting, and so forth. We also fine-tuned the model in a number of specialized medical domains across multiple modalities, and explored, again, a number of applications: health data classification, visual question answering, and radiology report generation. So I'm just going to perhaps finish with this example of MedGemini in a novel multimodal diagnostic dialogue setting. It's very much a one-off case study. We haven't done large statistics in this radiology setting in this work. So it's a somewhat anecdotal result. In this case, I role-played as a clinician who has received a patient x-ray, but has not yet received the radiology report, and conduct an open-ended dialogue with MedGemini. So in this case, the clinician gives the x-ray to MedGemini, explains the situation. MedGemini writes a radiology report, and it's kind of interesting. MedGemini identifies mild degenerative changes along the spine. The clinician can then chat with MedGemini about the report, like ask for an explanation of the evidence for these degenerative changes. And the model is very good at answering and giving an explanation, and for what evidence it sees in the image to support this claim that there is the presence of small osteophytes along the anterior margins of the vertebral bodies. So then in the dialogue, I pretend that the patient has a history of back pain and ask, could those degenerative changes explain this? And MedGemini then responds saying that this is possible, that follow-up investigations will be required though to identify the cause, and it's very sensibly noting that correlation doesn't imply causation, which is a very good answer in this case. And then finally, I ask for a report in non-medical terminology, which MedGemini then writes. I think this is interesting. For somebody like me who doesn't have radiology training, it's difficult to tell whether or not the original report is a reasonable reflection of the X-ray image, whereas the report written without medical terminology is much more readable for a general audience. Also, MedGemini is polite and helpful throughout, which is a great property. Now, once again, we can try and evaluate this more open-ended dialogue setting. And in this example, we do that by looking at the ground truth report, in this case written by a radiologist. And we see that the ground truth report does detect mild degenerative changes along the thoracic spine, similar to what MedGemini found. Then I also worked with a radiologist to evaluate the quality and potential of that dialogue. So the radiologist just read through the dialogue and gave some feedback. One theme that emerges is that they really like this open-ended interaction, and they say that it's more realistic than the previous Flamingo CXR type of radiology report writing. It's actually quite similar to how radiologists and clinicians actually communicate in clinical settings. Very often when a clinician sends an X-ray image to a radiologist, they will just talk to them, perhaps over the phone, or they'll chat briefly and quickly discuss and answer questions through dialogue. And although the radiology report is an important component, dialogue is also an important component. So, this, I think this is interesting because, well, there's two issues. One is that it's difficult to evaluate these sort of open-ended types of settings. We don't really have standard benchmarks to evaluate open-ended radiology-grounded dialogue. But the models, since the Flamingo CX4 work was published, have clearly started going in the direction where they have these sorts of capabilities, in this case with fine-tuning of Gemini 1.5. And I think it'll be really interesting for the field to start exploring how to evaluate and measure these types of capabilities. I won't spend, in the interest of time, I won't delve into the details of some of the other examples that we illustrate in this work. Suffice to say that we run similar qualitative tests with dermatology dialogue, also with medical education dialogue, in which the model demonstrates its ability to analyze a video and conduct a dialogue then with the student, learning about some procedure, in this case, a keyhole surgery. In this case, we see an example where it demonstrates capabilities on scientific information synthesis. And we also do some benchmarking. The examples I just showed, they're case studies. But we can still benchmark across some large data sets. We look at 14 different benchmarks spanning text, image, surgical videos, electronic health records, waveforms, genomics, and more. Achieve state-of-the-art in 10 of them, and also do some evaluation of MedGemini on long-form text-based tasks. Again, doing side-by-side comparisons with experts. In these cases, the MedGemini results are preferred over human expert results on tasks like long-form text-based tasks, medical summarization, doctor referral generation, and medical simplification as well. And as a very final result, we established a new state-of-the-art in the MedQA dataset, which consists of questions that are used as part of the USMLEs, the US medical licensing exams. Consisting, as you may know, of particularly challenging medical reasoning questions that clinicians in the US must pass to become licensed practitioners. And we achieve that then by training MedGemini to use Google search to gather, select, synthesize relevant and up-to-date information to answer difficult medical questions. But as I said, I didn't really want to delve into the details of those examples. I was really just wanting to highlight there some of the more recent developments in the last year since the Flamingo CX4 work was published, and demonstrating some of these new open-ended dialogue capabilities that are really interesting. And so, yeah, if you're interested in reading more about this MedGemini work, we published a pair of papers with all of the details. Once again, the culmination of a large team effort with contributions from Google DeepMind and Google Research, many excellent colleagues on both sides. Across the organization. Before I finish, I should mention all the research I presented today, it doesn't represent a real-world product. Our goal here is to explore the possibilities that AI presents in healthcare. And I think just one last reflection, just stepping back, I've presented a wide range of applications of AI in healthcare, from specialist applications and language models for radiology report generation through to multimodal dialogue. Touched on many results, but I think as a general takeaway, we now have this strong evidence that all these techniques, combining large language models with medical specialization, along with collaboration and evaluation with clinicians, I think it provides a really promising and interesting pathway toward the solution of many challenges in healthcare. From radiology and beyond. So thank you very much. Thanks for the invite. It was great to be able to talk at the 150th edition of the series. Thank you, Amara.
Thank you very much, David, for this very interesting presentation. So before we open the floor for questions, I'd like our audience to give our speaker a virtual round of applause for this excellent presentation. And with that, we have only a few minutes left, but if somebody has any questions, please go ahead.
Hi, David. Can we just go with the questions, or
Yes,
to raise
please.
my hand and wait for
Yes.
Okay.
No, please.
Hi, David. Thank you so much for your presentation. It was really great to see the work. I just wanted to ask a few questions related to the training. Basically, firstly, how you basically structured, like in the Flamingo setting, you do like an interleave kind of like image text kind of a setting. Do you do the same thing in your training procedure? Uh, and the second thing I wanted to ask about, you briefly mentioned about the mimic CXR dataset had a semi-structured kind of report, and the int dataset had uh, I'm not sure if it was structured or not. How did you how did you kind of deal with that during the training? Did you like choose only structured, or did you choose only semi-structured, non-structured data sets? And these are the two questions I have to you.
Thank you. Both great questions. Yeah, and as you can imagine, that was a focus a lot of the effort. So for training, it was interesting. We fine-tuned the model with the same kind of interleaving of images with text, and we also did ablations to see what part of the model is best to train. And we actually found that freezing the text piece of the model gave us the best results. So in the end, we were freezing the text piece, but the connective piece and the vision encoding piece were free to adapt. And of course, we back propagate through the text piece into the vision piece. So both the report and the image are contributing to weight changes. But I think that's probably perhaps not entirely surprising, because I would say, and I'm only hypothesizing, that X-ray images are much more different to natural images than an X-ray radiology report is to natural text writing. Even though the radiology reports are certainly not, the typical natural text that will arise in typical conversation and so forth. And then the second question about the structure, yeah, indeed there are differences with reports. I think anecdotally I've been told the Ind1 reports are more structured and templated to some extent. I'm not an expert, but anecdotally that's what I understand. And there are other differences. There's many more normal X-ray images in the Ind1 dataset, whereas the mimic CXR1 has many abnormalities because it's coming from an emergency department and the Beth Israel Deaconess Center. So to deal with that and make sure that those normal X-ray reports don't unbalance our dataset, in our training we weight the relative contributions of the different data sets with a weight in our loss function, and we essentially downweight the contributions of those high frequency exemplars, so that the overall algorithm doesn't become overly biased towards, in that case, normal data, normal X-ray images. Yeah.
Okay.
Okay.
Thank you so much for.
I think we have one question from Anis. Anis, please go ahead.
Sure. Hi, David. Thank you so much for the presentation. I just have a quick question about the impressions and findings section of the report. So, as you showed that some of the studies don't report any metrics for the impression sections, right? So I'm wondering what are the main driving reasons for that. Are impression sections kind of difficult to generate? Because based on what I have seen, most of the impression sections contain the summaries from the findings, right? So that means that most of the heavy lifting is done when generating the findings section. I'm wondering what are the reasons for that, and in your whole analysis, what thoughts do you have on this question?
It's a good question. I am not sure why. And like certainly the earlier studies focused on the finding sections. So unless it was, I'm only speculating, but unless it was a computational resource question for earlier studies, it might have been a natural way to shorten the amount of text that needs to be generated. No, I'm not sure. And certainly it seemed like a natural thing for us to do since we had that data available. And as you said, the impression is linked to the findings section, so you would expect there to be some benefit, not only for the impression section but for the findings section as well, to train on this extra data. More data is usually a good thing. So yeah.
Thank you. Just a quick follow-up. So did you calculate any metrics just for the impression sections in your analysis?
We focused on the full report, so you can't do direct comparisons to the results that only report on the findings section. Even though they're using the same metrics, but of course, if you're measuring something that's a lot shorter, there's an argument that it's an easier task to some extent, certainly in the output space. Yeah.
Thank you so much.
Thank you, David. I know we're over time, but there is one kind of general question from our audience. I think that would be interesting. So I want to ask this as a last question. So the radiologists, what do the radiologists you've spoken to say about the challenges in this area? How would they like to use AI to help them?
Yeah, it's a very interesting question. I think I don't want to speak, I guess, on behalf of radiologists, but certainly it's true that radiologists have a huge workload, and tools that can help them to address that, I think, are beneficial. I think the collaborative mode that we've explored is really important. For many reasons, safety reasons. Also, there was a very good question about the clinical context. Perhaps, there might be some clinical context that isn't available in the raw data, which a radiologist would be able to integrate. And it's only through that kind of collaboration that you could get the full picture. And so, yeah, I would say that those are the two points that jump to mind immediately, that there's a great opportunity here. And I think, but at the same time, there are many open questions. So certainly encourage anyone who's interested in this work to explore many of the questions that came up today. Yeah, I think it'll be interesting to see how the field develops over the coming years. So thank you again also for the invitation, and yeah, all the great questions.
Thank you very much, David. Excellent presentation. And we'll upload this talk to YouTube, and we'll share a link with you. Thank you very much, everyone. Hopefully we'll see you in next week. Thank you.